last names. Okay? Without further ado, we will start the first speaker. Her name is Heather Alvarez. She's a laboratory manager from Prairie Ridge Health, and that is in Columbus, Wisconsin. She's also a very enthusiastic and active lab tag member.
I apologize, I don't have much of a voice, but we're going to try and get through. So as you said, my name is Heather. I'm going to start us off today. We're going to kind of intro to sepsis, why we're here today, why we are spending an entire day talking about sepsis. All right, so nice picture I kind of took from the Mayo Clinic website, kind of a visual of how sepsis occurs. So essentially, the body has an infection, usually bacterial, can be viral also. The body then sends chemicals, protein immune mediators to help fight that infection. Those mediators can go unchecked and just kind of explode. It can trigger widespread inflammation, lead to blood clots, leaky blood vessels, impinge the flow of oxygen to your organs, and then organ failure for the patient. Sepsis occurs unpredictably, can progress very rapidly, and there's no specific treatment for sepsis other than treating the symptoms of the patient and then finding that underlying cause of the infection to treat that. Each year, at least 1.7 million adults in the US develop sepsis. At least 350,000 adults who develop sepsis die during their hospitalization or are discharged to hospice. 1 in 3 people who die in a hospital had sepsis during their hospital stay, and nearly a quarter to a third of people with sepsis had a healthcare visit in the week prior before they were hospitalized. So kind of some powerful numbers, which lead to a full day on sepsis. So I'm going to share some sepsis stories. These are not my patients with sepsis. These are stories that are taken from a website called Sepsis Alliance. These are patients who submitted their own stories and their own photos to share. So the first one up here is Levi. Levi survived sepsis and viral meningitis when he was 6 weeks old, caused by a parechovirus. The virus was in his CSF and central nervous system. He's now almost 4, doing great with some intellectual disabilities, tube-fed and nonverbal, but he is slowly improving. Next sepsis survivor here is Jess. Jess was pregnant, just shy of 34 weeks. She was sick, ended up being sick with strep A, started going into labor, went into the hospital. They took her for an emergency C-section, but when they tried to bring her awake after her C-section, they couldn't get her kind of heart back to where it should have been. She ended up being intubated, put into a medically induced coma in the ICU. She was told that if she hadn't come into the ED, neither her or the baby would have survived. The baby was totally healthy, had to be in the NICU for 26 days because he was early, and mom spent 21 days in the hospital, went home with a walker and a PICC line. Next story here is Jose. Jose was from Costa Rica. When he was 28 years old, he developed severe pneumonia. So sepsis from the pneumonia there. He ended up spending 72 days in the ICU, 82 total days in the hospital. Annette, sepsis from kidney stones. So she was diagnosed with a UTI, went on a road trip. The road trip ended up giving her, she resulted in kidney stones, ended up in septic shock. At the bottom there, sepsis from surgery. So this is Brittany, 29 years old, gastric sleeve surgery. Ended up finding out that there was a leak from that gastral sleeve. She ended up septic, 5 days in ICU, 4 days in med-surg, 9 more surgeries, 6 weeks of TPN. So some pretty heavy lengths of stay for your facilities. Right? These patients are spending a lot of time and resources in our hospitals. So where do we go from there? What do we do? The CDC has programs in place to help facilities kind of try to manage outcomes for sepsis because it's such a big problem. One of these is called the Hospital Sepsis Core Element Program. And what that does is collect data, and then it kind of shares it back to facilities in a way that they can compare themselves. So that all happens through the National Healthcare Safety Network, or NHSN. If in the laboratory you're not familiar with that, I guarantee your infection preventionists use that portal quite often. Sepsis is also a topic that's measured by CMS in their severe sepsis and septic shock management bundle measure. So this guides reimbursement for many of our hospitals and facilities throughout the state of Wisconsin. I can tell you as a critical access hospital, which some of you are, we're exempt from this measure, but the rest of us, these are the way we treat our patients with sepsis, determines how much reimbursement you get from CMS as a facility. So that bundle from CMS is a big bundle. It includes all of these things here. Some of them are lab measures. So collecting a lactic acid within 3 hours of the patient walking through your door, collecting blood cultures before your antibiotics, starting your broad-spectrum antibiotics within 3 hours, crystalloid fluid resuscitation, vasopressor administration, and then a repeat lactic acid within 6 hours. So this entire bundle from a CMS perspective is pass or fail. If you miss one element, you fail the bundle from CMS. Doesn't just affect reimbursement, it affects our patients too. So everything, there's a lot now that is visible for the patient. One of them is a website called Medicare Care Compare. So this is where patients can go look up any hospital they want in the state of Wisconsin, and it will give a ranking for that hospital on how well that facility does at taking care of their patients. And sepsis is one of these measures. So I couldn't share my own sepsis data because we're critical access and we don't have a number. It just says not applicable. So I randomly pulled some other facility in the state of Wisconsin. So if you look down there at the far right corner, this hospital's score for sepsis was 82%. They had 78 patients with sepsis. They scored 82% on their bundle for treating their sepsis patients. And then it gives you a national average, a Wisconsin average. So if you ever want to look up your facility and how well they're doing, you can go to the website there. And then that all goes into that overall star rating at the top. So this facility rated 3 stars out of 5 for caring for their patients. So kind of a big picture for sepsis, way beyond the lab, which makes treating sepsis much bigger than just us in the lab as well. So this is a team approach. Folks throughout your organization are all going to have to work together for your sepsis patients. And then I wanted to share a case study. So this is a patient case study from our facility. So this is October, last October. A 90-year-old male came into our RED for nausea, vomiting, fatigue. He's tachycardic, febrile, pulse ox kind of low. His right foot appears cellulitic. This is a chronic ulcer he sees podiatry for. Initial labs show elevated white count, elevated PCT and lactic acid. They order blood cultures, they order urine culture, and then they start the sepsis protocol. Patient was started on ceftriaxone, one of those, broad-spectrum antibiotics, and they admitted him to the hospital for possible sepsis. So this is the following day. Our blood culture bottles are positive. They show tiny gram-negative rods. This is not my gram stain because I don't still have a gram stain from October. So this is a picture of the organism that I found online. Anyone want to take a guess? Little gram-negative rod. Okay. They're good guesses. So we run a blood culture ID in-house on the Verigene. This is our Verigene panel. You can see it has limited markers there. Nothing on that panel is detected, although neither of the things I heard mentioned are even on the panel. So set up plates for ID and susceptibility. Maldi the following day gave Pasteurella. No susceptibility testing performed on the Pasteurella. We were told by a member of the nursing staff this patient has cats at home, although I could not find any documentation in the chart to support that, but would make sense with the Pasteurella. Patient improved and was sent home. 3 months later, same patient comes back to our ID. Nausea, abdominal pain, tachycardic, hypertensive, elevated lactic acid, although his white count's normal this time. Urine showed hematuria, positive leukocytes, bacteria. Urine culture and blood cultures performed. Urine culture grew greater than 100,000 colonies, Enterococcus faecalis. Blood cultures, both sets of blood cultures had growth in the Arabic bottle only. This was reported by the microtech at the time, gram-positive bacilli resembling diphtherides, and it was treated as a possible contaminant. He was sent home, treated for the bladder infection, and discharged to home. 3 weeks later, he's back again. Now, shortness of breath, nausea, chills, fatigue, decreased appetite. His urine looks good this time, so I think we fixed the bladder infection. Elevated lactic acid, elevated PCT, again, urine cultures and blood cultures. Following day, all 4 blood culture bottles are positive. All 4 gram stains show gram variable rods. They're these pink rods that have spots of purple included in them. Not sure if it's a positive or a negative. Staff set up a gram-negative BCID panel, because might as well try. Nothing detected. So maybe Pasteurella again. Doesn't quite look like a Pasteurella, but maybe. We inoculate the plates, incubate them, and then the provider orders 2 more sets of blood cultures, because we don't know what it is, so let's order more. Any guesses? Do you think it's Pasteurella again? No. Do you think it's something different? Raise your hand if it's something different than Pasteurella. Okay. So following day, we have growth on blood, no growth on McConkey. So we tried them all, DID on our prime. No ID. It gives us no ID. We could set up a Vitec ID panel, but we in our facility can't do susceptibility if it's a gram-positive rod, which is kind of what we're thinking. So rather than do work and delay it, we made the decision we're just going to pack list this up and we're going to send it to our reference lab for an ID and a susceptibility. So we pack list it, we put it in the incubator. An hour later, our next set of blood culture bottles is positive, and it looks like this. Is this the same thing we saw in the previous slide? Raise your hand if it's the same. Okay, raise your hand if it's different. Okay, that's kind of what we thought too. So that was my gram stain. To me, it looked different than what was before. It almost looks like buds, right, on the end of these rods. To me, they looked different. So I was done. I pack list this one up too, and we sent the reference lab both plates at the same time and just let them work it up in tandem. That way they have all of the information together. So reference lab gets our plates, and they do a gram stain that looks like that. So their notes, they're like, this is a gram-positive cocci. The note said this is a rod. I don't see my friends from St. Mary's Madison here today, but they did say that subsequent gram stains of this organism continued to get more pleomorphic as time went on. They were able to get a preliminary ID. Corynebacterium ulcerans was the preliminary ID they got. But due to the gram stain discrepancies they got along the way, and the fact that they can't do susceptibility testing in-house either, and it's a blood culture, they made the decision to send this organism to ARUP for confirmatory ID and susceptibility testing. So at this point, we had provider made a phone consult to infectious disease. Infectious disease recommended a high dose of vancomycin until we could get a susceptibility. Also recommended we transfer the patient for a TEE. He was concerned about endocarditis. The isolate was sent to ARUP. Their definitive identification was Corynebacterium ulcerans / Corynebacterium pseudotuberculosis. Pretty susceptible susceptibility pattern there. Patient was transferred, did have that transesophageal echocardiogram, but had a large hiatal hernia, so they couldn't see anything, so it didn't help very much. His plan, which is currently undergoing, is 6 weeks of IV vanco treatment and then more blood cultures when it's finished. So Corynebacterium ulcerans was new for us, especially in a blood culture. So kind of did some research, pulled some info from CDC here, from their emerging infectious disease. So according to CDC, it's closely related to C. diphtheriae. Some strains can produce a toxin that are similar to the diphtheria toxin. They consider it one of the most harmful pathogens to livestock and wildlife. It's increasingly recognized as an emerging zoonotic agent of diphtheria-like illness in the world. And while C. diphtheria is thought to be transmitted only among humans, C. ulcerans can be transmitted to humans by non-human mammals. Dogs and cats are considered the main causes of transmission to humans, which kind of fits with our patient who also had a pastorella from his cats at home. So in hindsight, right, that's the purpose of case studies sometimes, is to look back. I suspect his contaminants with his bladder infection were actually the start of this C. ulcerans infection, even though the patient did seem to be improving from his antibiotic. There's value in reviewing cultures for patients over time. It lets you detect patient trends or even make changes to how you do things in the future. So in this case, it was working back with that microtech to say, like, gram-positive rods resembling a diphtheroid in a blood culture is really not enough information for a provider to make a decision. So need to do some work on how that gets reported in the future. And then a reminder that just because we identify an organism doesn't mean it's an infection. It's unfortunately too easy to contaminate a blood culture, which we will talk about later today. But then you get your providers scratching their head because now, do I treat it or do I not treat it? So our goal, right, is to only identify things that are a problem if we can get there. Any questions? Then I think we move on to the next one, right?